Hello, I'm Chris Sharp. I'm one of the Regional Workforce Development Managers for the Office for Health Improvement and Disparities here in Yorkshire and the Humber. This is just a short 15-minute presentation on making every contact count. So what is making every contact count? One of the early tasks of the MECC advisory group was to agree a core definition of making every contact count. We needed to have a common understanding of what MECC is and, importantly, what it isn't. In order to evaluate MECC, we needed to be clear on what we were delivering and the expected outcomes. This is a core definition that applies across health and care to both public health professionals and the wider public health workforce. Making every contact count is an approach to behaviour change that utilises the millions of day-to-day interactions that organisations and people have with each other to support them to make positive changes to either their physical or mental health and well-being. It is opportunistic, at scale, and consistent. So how have we traditionally defined MECC? I've got a really important statement here that if the nation fails to get serious about prevention, then progress on healthy life expectancies will stall, health inequalities will widen, and our ability to fund beneficial new treatments will be crowded out by the need to spend billions on wholly avoidable illnesses. Many long-term diseases in our population are closely linked to known behavioural risk factors. So MECC was established to have conversations linked to these modifiable risks. For some, the key causes of disability-adjusted life years attributed to tobacco, hypertension, alcohol, being overweight, or being physically inactive. So making every contact count conversations primarily focused on supporting people to quit smoking, eating a healthy balanced diet, drinking alcohol within recommended limits, promoting good mental health, or engaging people to move more. A MECC conversation is a recognised behaviour change intervention, a very brief intervention, anything between 30 seconds and a couple of minutes. This is to raise awareness and motivate, signpost people to help them improve their health and well-being. In Yorkshire and Humber, we try and keep this as simple as possible using an ask, assist and act approach. So the ask part is taking the opportunity to get the conversation going, assessing how you might help. The assist, in light of your understanding, offering information that is personalised and appropriate. We can replace assist with advise for clinicians, as there is more of an expectation that clinicians should provide advice on health matters. And finally, encouraging people to use self-care tools, resources, or this could include signposting people to a range of national and local support services. So a MECC conversation should also help increase a person's psychological capability to undertake a behaviour change. And for that, we integrate the Cone-B model for behaviour change. And that argues that behaviour change occurs when there's an interaction between three necessary conditions. And that is somebody has the capability, opportunity, and motivation to make a change. And that behaviour change occurs when there's an interaction between all three. So on the next series of slides, we're going to have a look at MECC and CVD prevention. So on the left-hand side, we've got a series of modifiable risk factors for CVD, things like smoking, high cholesterol, high blood pressure, harmful drinking, physical inactivity. So these are the kind of typical MECC conversations. But there are also a series of environmental and social factors as well, things like family history, financial inequalities, employment, housing, air pollution. And if I'm honest, the tendency for MECC is just to focus on modifiable risks, which is okay if you have a choice. We regularly ask participants that have gone through some of our training, what has the greatest influence on health outcomes? Now, it's generally a close-run thing between individual behaviours and social and environmental inequalities, but individual behaviours regularly comes out on top. Now, social inequalities have something like a 40 to 50% impact on our health outcomes. So that's greater than healthcare and individual behaviours and genetics combined. As part of a training, we take people on a bit of a bus journey and talk about lifestyle factors, lifestyle choices and personal responsibility. In this particular infographic here, you can see A bit of a life expectancy bus journey from Leeds to Scarborough. This follows the coastliner bus route. You can see there that Leeds bus station is in some of the highest deprivation quintiles that we have. Life expectancy for women is 79, life expectancy for men is 72. And you can follow that bus journey up through the deprivation quintiles to quintile 1, where you can see there Cockmanthorpe Hall Lane with a life expectancy of 88. And that's increased by something like 9 years for women. And for men, it's an increase of 14 years, which is incredible. And then you can see declines going through the different deprivation quintiles until we get back to deprivation quintile 5, where life expectancy, again, is significantly lower. So at the end of the previous slide, we ask if somebody in deprivation quintile 5 has the same choices as those in deprivation quintile 1. The answer is clearly no. They have less choices and ultimately poorer health outcomes. And this can be seen as more of a mirror image when it comes to emergency hospital admissions for coronary heart disease. So you can see this infographic here uses the same coastliner bus route. So we start in Leeds bus station in deprivation quintile 5, and the figures here are much higher than those if you progress into quintile 1, which is on the kind of leafier, more rural parts of York. And as the bus journey continues, you can see hospital admissions rise fairly steeply until we get to Scarborough, where the numbers are significantly higher. So this kind of gives a really strong indication that these are not lifestyle choices. You have less choice. You have less choice about physical activity. You have less choice about access to healthy and affordable food. Less choices about the environment that you live in. Less choice about transport. Less choice around employment and income. Helping to tackle health inequalities is key to providing choice in our health behaviours and our modifiable risks, which in turn lowers CVD risk and premature disability and death. A person-centred conversation should therefore always include the wider determinants of health. So I've got a bit of a question for you, and it's, would it be possible to state that our MECC conversations on affordable warmth and say the cost of living crisis can help prevent CVD? I'll leave that one with you, but in essence, help with affordable warmth and the cost of living support isn't ignoring CVD risk, it's actually helping to tackle it. So we've looked briefly on the fact that a lot of this isn't down to personal responsibility or the fact that people have choices. It is a combination of modifiable risks and wider and social determinants of health. But for this particular aspect here, we're going to concentrate on smoking, because if we can do anything to help people quit smoking, it's going to make a significant difference. So this is kind of an example of the MECC approach for stopping smoking. So here we've got the askers, have you ever thought about stopping or tried to stop before? And that way you could state the best way of stopping smoking is with a combination of medication and specialist support. So once you've engaged that conversation, the assist part is, do you think you would benefit from the services of your local stop smoking service can offer? Studies show that you are 4 times more likely to quit if you do this through a combination of specialist support. And then the ACT part, which is the important part, and this is the signposting or referral to a range of tools, resources, national and local support services. So here we have the capability. Have you tried stopping smoking before? The opportunity, what support they might get, does this work for them? And finally, the motivation. It could be health, it could be financial, it could even be family concerns. In Yorkshire and Humber, we have a Making Every Contact Count community of improvement. And one of the things that we asked is, how can we better support people to have a MECC conversation? And so one of the things that we discovered is that people would be less likely to start a conversation if they didn't know where to signpost people to at the end of it. So that could be signposting people to self-care resources, national support, or local support services. So we've already looked at the fact that there are already quite a number of modifiable risks, but add that to some of the wider determinants of health as well. It's almost impossible for you to retain this information. So we developed what is essentially a website, but it would provide a flexible resource that would support both the confidence and competence to deliver healthy conversations and signpost people to sources of self-care, national and local support services. And it would do this all in one place. This is called MECC. So in this point in the presentation, I would ask you to get your mobile phone out and go to www.mecclink.co.uk, which is our primary signposting site for Yorkshire and Humber. If you would select the option on the drop down for Yorkshire and Humber, you're then presented with essentially a series of categories and locations. And the idea behind it is that it provides all the information that you need in one platform. So if I go to smoking, for example, you can see here, you can see there we've got a bit of some information about the benefits of quitting, for a bit of a reminder for that particular user. But then it's got the Ask Assistant Act. So the Ask Assistant Act are not the questions to ask, but they kind of give an indication to the person that's having those conversations that there are some examples, you could say. So for example, have you ever thought of stopping or tried stopping smoking before, as we've seen on the other one? And then there's a little bit of information there about benefits in terms of the financial benefits as well. That's a motivation for that particular individual. The assist would be the best way of stopping smoking with a combination of medication and specialist support. And this is where it really comes in, because the Act tab has got details of all the national support services, the self-care, and then the next tab is the local support and contact details. So this ensures that the person that's trying to have that making every contact count conversation doesn't have to retain all this information. They just need to know that MECC is there, and they can navigate to the source of the information they need as quickly as possible. So in this case, the user is going to smoking all the way through the Ask Assistant Act questions to Barnsley, where they can find details of the smoking cessation service for Barnsley, which in this case is Yorkshire Smoke Free Barnsley, and that'll give information around the telephone number, the website, and that could even be opening hours. And it does this for every tab and for every local authority in Yorkshire Humber, and we've got 15 of them. So it's been, I'd say, a bit of a labour of love over the years to build up this database of some of the primary signposting sites and some of the key national support services that go along with that, along with some of the self-care tools that we have. So have a look at it and see how it can be embedded into some of your own working environments, because we'd love this to be widely used by you. One of the benefits of having this on a website is that we can track the fact that actually people are having making every contact count conversations through the hits to the website. So you can see there's various peaks and troughs of this being used over the last few years. And we can also drill this down to what topics people are selecting as well. So we know that, for example, more people are having conversations about mental well-being and alcohol and smoking than they are about some of the other categories that we've got, which is useful information, because not only can we track, the fact that actually this app is being used, but actually as a result that we believe that people are having these making every contact count conversations. One of the things that we're keen to do as well is embed this within an organisational commitment to improve population health. There's also an opportunity to link this to staff health and wellbeing as well, because a MECC approach is much more likely to succeed if staff have the opportunity themselves to improve their own physical and mental health. So this is really about recognising that organisations have a place as an anchor institution, as an employer, but also as an organisation that is committed to improve the health and wealth of its population. So I just wanted to conclude with a little bit about MECC training. So training on MECC is recommended, but this can be flexibly delivered and fairly light touch. But training should be focused on an understanding of the determinants of our health, not just modifiable risk factors. And some of these aspects are really around, I guess, gain an understanding of why health inequalities impact on our choices and to try and address that within our kind of conversations about modifiable risk factors. The understanding that conversations around the wider determinants of health do contribute to things like CVD prevention, even though, you would say that the most important part are generally the kind of modifiable risks. But we'd also need to ensure that people are comfortable in applying the very brief intervention, so the Ask Assistant Act. So any of the training that we do provide is very much focused on that. We do not necessarily focus on the signpost inside because we very much take people through the MECC link website. So you don't need to retain all this information, and hopefully it's kept all live and updated. So this is the point I would normally field your questions, which I unfortunately can't do today. But I'd love to hear from you if anybody has any questions or anything that they think that they can implement back in the workplace. Please do contact me. My email address is chris.sharp@dhsc.gov.uk. And thank you very much for listening to my presentation today. Thank you.